is the 12th series in our Friday lectures. Earlier we had 11 such series. The today's topics are foreign body, GERD, Barrett's esophagus diagnosis and management. Second topic is corrosive poisoning esophagus and Achalasia cardia. The third is carcinoma of esophagus. So we have two eminent chairpersons today, Dr. Kamlesh Khandelwal and Dr. Sanjay Sonar. Before I start introducing them, I'll ask our president, Dr. Niranjan Agarwal, to say a few words, and then we'll start the session. Dr. Niranjan Agarwal.
Good evening, friends. It's Friday again, and you're hearing me. A warm welcome to all of you. This is the 12th series, and with this, we start our systemic organs lecture series. The first to start is with the esophagus, and as Rajesh has already pointed out, not only the speakers are highly talented people in this field and highly senior people to the designation of HODs, etc. in their departments, the chairpersons are also highly designated people. So I am sure the deliberations which are going to happen today is going to solve so many things, and those PGs who are logged in today will definitely benefit as far as not only their exam but how to go about their practice. And those practicing people who especially in the nursing home sector who find it difficult to deal with esophagus and etc. will get updated upon what is new and how to deal with them. Apart from the surgeon, as before we started, a medical gastroenterologist was is here rather, and going to open the batting. He was very humble to say that he is the only non-scalpel person, but I must say that he is the one person. He is one of those person who has snatched away scalpel from most of us. But we are happy for that. It's not that we are unhappy about it. Wherever things are benefiting patients, we are more than happy. And lastly, thank you, Juventus, for again hosting the whole thing and helping us out. Over to you, Rajesh, so that you can introduce the chairperson and the session can be started.
Thank you, Niranjan. Our first chairperson is Dr. Kamlesh Khandelwal. Dr. Khandelwal is Director Surgery Department, Jaslok Hospital. Dr. Khandelwal is attached to various hospitals in South Bombay. He's been a senior consultant. His keen interest is hepatopancreatobiliary surgeries. He has presented many national and international papers in various journals, and he has many publications to his credit. Dr. Khandelwal has been one of the few pioneers in early laparoscopic cholecystectomy, Dr. Kamlesh Khandelwal. And Dr. Sanjay Sonar is a laparoscopy and scopy center and is attached to Bridge Candy. I think Dr. Sanjay Sonar has his own hospital, and his also keen interest is basically laparoscopic surgery. I think Dr. Sanjay is keenly interested in laparoscopic hernias and of course laparoscopic HPB and GI surgery itself. So over to you, Dr. Kamlesh and Dr. Sanjay, to start the session. Yeah, thank you.
Sanjay, I think you start, please.
Yeah. Thank you so much. Thank you so much. Thank you, Dr. Niranjan, for the lovely introduction, and thank you, Dr. Rajesh. Can we start the first speaker session? May I request Dr. Meghraj Ingle, sir, Professor and Head of Department, Siam Hospital, and a Senior Gastroenterologist, to please start his presentation.
Good evening, everyone. Just a second. I hope my my slides are visible.
Oh yes.
Yes. So
you can make it full screen. You can make it full screen if you don't mind. Yeah.
Is it not full screen? It's showing full screen on my this. Just give me a second. Yes. I will just stop share and just start it again. These things occasionally have. Just 1 second. Just a minute. Is it full screen now?
Still showing the bar of slides on left hand side, Dr. Meghraj.
Oh, just sorry.
We can start the slideshow probably, and then this will disappear. Yeah.
I have actually started the slideshow itself. I
It
don't
will
know.
just
Please,
take a sec. Just take a sec.
Yeah.
So click on that once again.
Yes. I will. Yeah. Is
Yeah.
it?
Perfect.
Yes. Yes.
Yeah, perfect.
Yeah. Okay. So, sorry for this for the technical thing. Thank you, everyone, and I welcome everyone to start this first session. I am grateful to the Mumbai Surgical Society for inviting me for this lecture, and yeah, and to be in the presence of so many esteemed surgeons. So the topic that has been given to me is foreign bodies, GERD and Barrett's esophagus, diagnosis and treatment. I will try my level best to accommodate these three topics into the time available. And then probably we can have a little bit of discussion after the end of the sessions. So we start. So when you say foreign bodies, usually it means accidental ingestions of the foreign body. In approximately more than 3/4, around 80% of the cases, the patients would be children. In adults, yes, you can see occasionally, mostly in adults with psychiatric disorders. However, sometimes it can also be seen as an accidental ingestion in adults without psychiatric illnesses or in elderly gentlemen. Occasionally also in mentally differently abled, and sometimes we do get patients from the or prisoners who have been trying to ingest something as just trying to get out of the prison. Now, the foreign bodies that you see in various sizes and shapes, but the common ones that we see very frequently are the coins, the disc batteries. We see toy parts, crayons are very common among children. Occasionally sharp pointed objects like pins and needles. These are commonly seen in females. Many times while sieving or when they want to touch, they hold it at the corner of the mouth, and accidentally they tend to ingest. So that needles are occasionally also brought to us by dentists. Sometimes when they are doing any dental work, and a small instrument sometimes slips off, and we have done it for a couple of our dentist colleagues. Fish and chicken bone common in, again, children, also in adults. Large food bolus. Jewelry is common more in children because the child that is on the lap or on the mother is hugging the child, and that's when they tend to generally by mistake ingest the jewelry either on the neck or the ear jewelry. And then dentures, as we know in elderlies, nowadays we get the permanently fixed ones, but then many people have the old dentures, and that can be also swallowed accidentally. So if there is a clear history and if it is witnessed, then there is no doubt. However, the issue comes in diagnosing when there is an unwitnessed things, and then patients can present with varied presentation. Common presentations could be just a foreign body sensation, but patient is not, or the person is not sure whether he has ingested or not. Commonly seen after a fish bone or a chicken bone ingestion. Dysphagia, retrosternal discomfort, these are the common presentations. Sometimes just difficulty in swallowing of saliva. Patients can come with it that after a meal, since the last 12 hours, not able to swallow anything, or just bringing out whatever the patient is swallowing. This again is one of the common presentations of foreign body ingestion, and generally it indicates a complete obstruction and requires a more urgent or emergent treatment. Localization by the patient is more accurate if it is an upper esophageal obstruction or upper esophageal this. However, if they are pointing to the upper, a lower esophagus, it can be a foreign body in the lower esophagus or in the upper. So a lower esophageal localization is less accurate than an upper esophageal localization. in very young children, poor feeding, gagging, or just irritability, those who cannot communicate, irritability is can be one of the presenting features. Sometimes a large foreign body can sometimes press on the trachea, and you can come with patient can come with a wheezing, dyspnea, rarely stridor, and this is the case where the confusion arises whether the foreign body is in the esophagus or actually in the airway tract. And when such a patient comes, the couple of things that are important from the clinician's point of view is to do a thorough physical exam, especially focusing on the airway patencies, the vital signs, and to look for whether there is a lot of secretions of the saliva that the patient is bringing out. Yes, you have to auscultate to look for abnormal breath sounds, to look for presence of tenderness or this in the neck, chest, abdomen, look for any subcutaneous air or crepitus. Sometimes a foreign body can cause a minor perforation. You can have a crepitus around the neck or the chest areas. And then, yes, of course, if the patient comes with vomiting of blood or hematemesis, then it generally is a sign that needs urgent intervention. So whenever you are evaluating a patient who has come with a said foreign body ingestion, you have to first evaluate in the type of the foreign body, the time lapse, because the type and the time lapse helps us in the urgent or emergent or elective management of these patients. Whether the patient has gone to other doctor or hospital and any attempts to removal were done. If done, then it helps us in knowing what we are dealing with. What is the type of dysphagia, if at all the dysphagia has happened. And from the intervention or endoscopy point of view, yes, time since the last oral intake, especially if it is a kid, because there is a tendency of the family members and the parents to give soft foods like banana is very common. We see patients, they have been fed banana so that it passes off and doesn't cause any injury. And then, yes, if there is a radio-opaque foreign body, then it's always a good idea to get a neck, chest, and abdomen imaging in the form of an X-ray done. This is what normally, most of the times, this is a coin. The figure on the right might look like a coin, but what the arrow is pointing out to is a halo sign. And this is what is seen in a disc battery. It is similar in size and shape to a coin, but X-ray sometimes is useful. And why it is important is that we all know that disc batteries require a more urgent and emergent therapeutic intervention. Unfortunately, parts of toys or plastic, wood, aluminum are not radio opaque. Bones sometimes or glass might not be seen on X-ray. But if there is a high suspicion, either an endoscopy if available or you suspect a complication, then CAT scan can be done. So as I said, in the first part of management is to evaluate the airway and secure. If the patient is unable to manage the secretions, they are at high risk of aspiration, and then they need to be managed urgently. And if the X-ray shows a proximal foreign body, then endotracheal intubation is appropriate. As I said, the type and the timing of ingestion helps in knowing when we can plan removal. If the patient has esophageal obstruction or disc battery or sharp foreign bodies in the esophagus, then they need an emergent attempt at removal. Urgent within 12 to 24 hours if there are esophageal foreign objects, but they are not sharp or not a battery, and patient has food impaction but not a complete obstruction. And non-urgent could be just coins in the esophagus that have been observed, or coins in the stomach that have been there for 5-6 days, and before in patient does not have symptoms, or the coin ingested is for the size of the patient. Endoscopies commonly used. Many times our ENT colleagues also in the upper esophagus with a rigid scope remove these foreign bodies very successfully. So adult upper GI endoscope can be used in children above 5 kg weight. Below that, it becomes difficult because the pediatric endoscope does not have a channel large enough for the accessories to pass. So in a child which is less than 5 kgs, it becomes a real issue. Occasionally we also use accessories like rat tooths, loops, snare basket, and over tubes. If there is a food bolus impaction, which is another common foreign body, though it's not a foreign body, but a food bolus impaction, there are two ways of dealing with it. Either you can try pushing it, or you can try removing it en bloc or piecemeal. There are differential data for both. Some say pushing increases the risk of perforation, but there is a data that shows there are two studies, though not very recent, which have shown that pushing the risk of perforation is not more than when you're trying to remove it by pulling or en bloc or by piecemeal. However, don't use any proteolytic enzymes because they can harm the esophageal mucosa and risk of perforation is there. Whenever a foreign body is impacted or a food impacted, always think of underlying esophageal abnormalities like a stricture, web, eosinophilic esophagitis. If you suspect strictures and webs would be seen, tumors would be seen, diverticuli would be seen. But if you suspect eosinophilic esophagitis, then you will have to take biopsies to prove it. And neuromotor disorders will normally give history of recurrent such episodes. And again, then further evaluation in the form of manometry can be helpful for evaluation of these of the underlying esophageal conditions. Coming to the next part of my topic, that is GERD. I understand GERD and Barrett's are actually very extensive topics, and you actually have textbooks written on them. So I'll try to cover the important points, and probably then we can take a few things during the discussion. So gastroesophageal reflux disease, also commonly called as GERD, one esophageal condition where there is a significant and distinct overlap between the medical and the surgical team for the evaluation and management of these patients. So what actually is GERD, where it's commonly called as heartburn caused by reflux of the stomach contents into the esophagus. Various studies have shown population prevalence ranging from 8 to around 20-21%, and there is equal prevalence in both men and women of this condition. Commonest symptoms is a heartburn and regurgitation. Occasionally, patients can complain with pain. Non-esophageal symptoms like cough or hoarseness of voice, dysphagia to solids because of either a complication of GERD or a change in the esophageal motility, history of recurrent aspirations, wheezing or respiratory complaints can be there. Occasionally, patients can just come with recurrent or intractable dental caries because of the GERD. And sometimes patients also come with the feeling of foreign body sensation or a globus. There are a few alarm symptoms that you should keep in mind when you are evaluating a patient on GERD, because that tells you when you need to intervene. This is when you just need a trial of medication. That is, patients having an acute onset of anemia, patient having an acute onset of dysphagia, any patient with history of GERD and hematemesis within a day, or melena, that is GI bleed. Patient with GERD with persistent vomiting for 7 to 10 days not settling. Again, we could be looking at a complication of GERD. And when there is a rapid short-term involuntary weight loss. So all these are alarm features and would mean that you should test and treat, and not treat and test such patients. So how do you diagnose GERD? Well, a presumptive diagnosis of GERD can be established in the setting of typical symptoms of heartburn and regurg. Occasionally, patients can just present with non-cardiac chest pain because of GERD. In this patient, a cardiac evaluation should be done to exclude the cardiac cause. And these patients also normally require a thorough diagnostic evaluation before labeling GERD as the cause of the chest pain. As I said, it is not required initially in the presence of typical GERD symptoms, the upper GI endoscopy. It is recommended only in the presence of an alarm symptoms, and believe it or not, it is coming from an endoscopist and a gastroenterologist. So we don't do or advocate endoscopy initially in every patient with typical GERD symptoms but no alarm symptoms. We would give a thorough trial of lifestyle modification and medication, which I will discuss later. When we do endoscopy, what we are looking at is whether the esophagus is normal or not, whether there is a predisposing factor like the laxity of the lower esophageal sphincter or a hiatus hernia, And at the same time, if there is an erosive GERD, we are trying to see the severity of the erosive GERD. Well, there are, as you know, various staging or systems adopted across the world. However, for maintaining of uniformity, what most societies would want to follow is the Los Angeles or the LA grading, where it is mild to the most severe. There is LA grade A, B, C, and D. Just to explain, it's a mucosal break or erosion, 1 or more less than 5 millimeters is A, 1 or more than 5 millimeters in length is B. Touching the top of folds, however, not completely circumferential or stricturous is grade C, and circumferential mucosal breaks or erosions or ulcers along with or without strictures is grade D, GERD. So coming to the more definitive diagnosis of GERD is you have the pH monitoring system, which is catheter based and wireless based. Again, I have not discussed too much in detail, but what we know is the conventional 24-hour catheter based pH monitoring, which can be done. Many times, if you want to differentiate it from a non-acid reflux, we use what is now called as the intraluminal impedance pH monitoring. Occasionally, you can also have a wireless based system that is a 48-hour or 96-hour Bravo pH monitoring. But more common is the dual channel pH or the multi-channel intraluminal impedance pH meter. This is the conventional one on the left. What you see on the right is the Bravo capsule. The scale is kept to just show you the dimensions of the capsule. Impedance pH monitoring, as I just mentioned, is commonly used in patients with refractory GERD, where we want to identify acid or non-acid reflux that will require some escalation of therapy. In patients with persistent belching, you are not sure whether it's a supragastric belch or a gastric belch because of the reflex. Sometimes in patients with reflux-related cough, if you want to completely diagnose, then you combine the pH, impedance pH, with an acoustic detection of cough, and then with the pH changes or in the impedance, changes in the impedance, whether you can get the cough, and that has a more accurate assessment. Again, this is not very commonly used, but is occasionally difficult to diagnose or treat situations. We use this impedance pH monitoring, and again it helps us to differentiate acid versus non-acid reflux. How we diagnose is that when more than 80% reflux episodes are occurring in more than 24 hours is definitively abnormal. Less than 40, you have to understand that normally also some amount of reflux is bound to happen. This is how we let out some air. And so less than 40 are physiological. Also, along with that, what we look at is the acid exposure time, or AET. A time less than 4% is normal, and anything more than 6% is abnormal. And also, but there are certain things that we need to keep in mind, whether what type of reflex monitoring was used, conventional or impedance, and also whether the monitoring was done off or on PPIs. So yes, it is easy to diagnose reflux. What is important is that once you have made a clinical diagnosis, or with the help of one of the pH or impedance, or you've done endoscopy, what you need is how you manage these patients. Well, lifestyle modification is the key and one of the most important things for managing GERD. So smoking is an absolute no. So also alcohol, both are categorically proven to increase the reflex, the GERD episodes. Patients need to lose weight because now there is a direct evidence that losing weight increases the tone of the lower esophageal sphincter and thus decreases the chances of reflex episodes. Small frequent meal, again, not increasing the capacity of the stomach, thus lesser chance of a reflux. Wearing of loose fitting clothes, especially just pre and post meals, helps. Avoid lying down to maintain that angle for 3 hours after meals. In patients with increasing symptoms or nocturnal symptoms, we ask the patient to elevate the head of the bed, and this is done best by putting a 6 or 8 inch block behind the head end or the bed post, not by taking 1 or 2 pillows, because that just increases the neck and puts you at risk of neck pain in the very near future, by causing no relief in your symptoms. And certain foods that we know are aggravating reflux. However, there is no data to it, whether excessive caffeine, dark chocolate, mint, uh, Coke-based soft drinks. These are all, there is some evidence. However, there is not enough evidence to recommend strongly. Yes, but it can be advocated as a lifestyle change in patients with intractable or difficult to treat reflux episodes. Medical management, well, antacids can be tried. They just give you some symptomatic relief, no role in healing of the erosive esophagitis. Recently, rat-forming agents are now widely available, Gaviscon alginate containing one. What it does is it just forms a raft above the gastric pool. This diagram here will show us, and prevents the reflux of the acid contents, and also the acid pocket which is in the fundus and the cardia gets neutralized. This acid pocket is known to be the more the common proponent of the reflux. Active receptor antagonists have been around for a long period of time, cimetidine, ranitidine, famotidine. There is no data to choose one between the other. It improves heartburn. Esophagitis healing occurs in up to 2/3 of the patients. More useful in controlling the nocturnal acid breakthrough along with a daytime PPI is when we normally use it. Proton pump inhibitors are the main modality of treatment along with the lifestyle modification. It just inhibits the meal stimulated nocturnal acid secretion, does not cure the reflux, please remember, but it decreases the number of acid refluxes and reheals the esophagitis in around 80% with a number needed to treat of 3. Other drugs that can be tried, again, there is not enough data, but yes, it can be tried in refractory patients who are not amenable to any form of an endoscopy or not willing for any form of a definitive endoscopy or a surgical therapies. You can try prokinetics. However, many of these drugs, especially metoclopramide, levosulpiride, have certain side effects, so to be used in caution. Transient lower esophageal sphincter relaxation, which is a normal physiological phenomenon, as I said, which happens physiologically. However, when it happens for a longer duration of time or more frequently, it can lead to reflux. Baclofen is one drug that can inhibit this TLESR and can be tried nocturnal, but we are aware of the side effects like drowsiness. And so you should be very careful, especially when prescribing it to a patient already on multiple medications or in elderlies or very small children. Endoscopic management, well, I will just quickly run through. There are various modalities that have been tried, not very common in routine practice, have been tried in experimental basis, like delivery of radiofrequency heat to the LES as shown in the cartoon, where it causes fibrosis and just increases the tone of the LES. You can inject a bulking agent and decrease the gap and thus increase the tone of the LES by injecting a bulking agent. Also trying to inject some submucosal implants, which can again bring the lower esophageal sphincter closer. Well, again, a little bit of overstepping on the surgeon's boundaries is when we try to placate the LES using the barred endocinch. Again, used in only high volume centers and only few centers across the country and the world. Also, GERD-X is now the new baby for the endoscopists, where there are various implications of using the GERD-X. Just enhances suturing, and this has been again tried. This is the cartoon that shows how it can mimic a sort of fundoplication endoscopically, and there are many videos and many experts, few experts actually who are doing this. However, there is not, as of now, not enough data to be recommended as a first line of therapy. Surgical, whenever intervention in the form of anatomical intervention is required, surgical management still is the go-to thing, and it corrects the physiological factors contributing to GERD, thus eliminates the need of long-term medications. It decreases both acid and non-acid GER by increasing the basal LES pressures and inhibiting the complete LES relaxations. this is a surgeon's gathering, so I'm not going to discuss about the various types of fundoplication. I'm just going to show this this cartoon in the hope that I don't face any question regarding to the surgical techniques, which I will be more than happy to pass on to my surgical seniors and colleagues here. One of the things that has been tried is the surgical placement of magnetic bead, that is the link system, which increases in the food bolus and then brings it back to normal when there is no swallowing initiated. And as shown by the left cartoon, thus decreases the risk of reflux. This is again an experimental modality as of now, not widely available and practiced, though practiced in certain high volume centers dedicated at treating esophageal disorders. Coming to the last part, which is a continuation of GR, is Barrett's esophagus. It is one of the effects of long-term reflux, and it's a condition of where there is abnormal columnar epithelium that replaces the stratified squamous epithelium, which we know lines normal distal esophagus. And why is it important? Why is it discussing? Because we know that it can predispose to malignancy. There was various types of breeding, like the long segment versus the short segment, where 3 centimeters was supposed to be the cutoff, where the long segment ones were more predisposed to develop complications and more predisposed to develop malignancies. However, I think there is some the differing data on long versus short. Dysplastic versus non-dysplastic, well, this is where it is important. And there is data to show that in patients with long-standing GERD, in fact, they're more likely to have a short. The frequency of short segment GERD is up to 20%, and long segment GERD can be seen in up to 5% of such patients. While describing Barrett's, there are various classifications, but for the sake of uniformity, what is practiced by most centers and most endoscopists is the Prague Barrett C and M classification, where C stands for the circumferential extent and M for the maximal extent. It will be more clearer in the next cartoon. Yeah. So this is very is the GE junction. So this is the circumferential extent from the GE junction, that is from 39 to 40. And the maximal extent is 36 to 40. So this this would be labeled as C1, that is 40 minus 39, and M4. So this would be labeled by an endoscopist as Barrett's esophagus C1 M4. Why this is important is when you are going to follow up these patients on therapy or without therapy, surgical or medical, increasing size or change in the contour of the Barrett's is an important indication that we need to be more careful about such patients. As I said, to localize dysplastic or non-dysplastic segments, various modalities have been used. Is high definition endoscopy. Then you try to change the color by something called as chromoendoscopy, where you use Lugol's iodine or methylene blue, where Lugol's iodine stains the normal glycogen containing mucosa. So what is abnormal will remain unstained. Similarly, methylene blue, because methylene blue is absorbed by a small, so the abnormal mucosa will pick up the color and the normal mucosa won't pick up. So it is used in detecting early cancers or dysplasias in Barrett's esophagus and metaplasia. So this is what I was trying to say. In white light, it is sometimes very difficult to pick up those areas, but the same areas can be picked up much better when you give an enhancement with the Lugol's iodine. What has changed is, as we all know, is the narrowband imaging or the NBI, where you change the depth of light penetration based on the wavelength. So you just put a filter at a click of a button and change the penetration so that you get more information about the deeper areas. And just to give an example, I'm not going to discuss in detail in this forum. This is what a normal mucosa would look like in a narrowband imaging. This is what a Barrett's esophagus will look like, where this is all NBI on a high definition on a closed focus. So it is a technique that needs to be learned and your eye needs to get used to it, but it's not very difficult if you have the scope and the monitor. And this is the irregular mucosa in Barrett's. What it does is that it tells you where to take the biopsy from also. So doing chromoendoscopy can sometimes become a little messy. So this is the easier way is to do the image enhanced endoscopy. I have used narrowband because it belongs to a particular company. Because it's the most commonly, but you have similar principles of iScan and FICE in the respective Pentax and the Fusion scopes also. Another principle is autofluorescence imaging based on the fluorescence of the particular tissue on exposure to a wavelength. We'll not discuss in detail. What is important in Barrett's is if you're doing endoscopy and direct Barrett's, you have to take biopsies. Well, there is a Seattle protocol which is used. It's a very extensive protocol where you have to take biopsy first from suspicious areas. If everything looks similar to you, then every 2 centimeter 4 quadrant biopsies. So imagine if it's a 6 centimeter Barrett's, you have to take 4 + 4 + 4, 12 biopsies. Not very feasible in our country because each specimen goes and is charged differently to most of the time into the patients. However, this is the protocol where here they label it. This is a chance to pick up early dysplasias or cancers in Barrett's esophagus so that they can undergo minimally invasive procedures. So what we do when you find Barrett's, one is you have to treat with PPI irrespective of the patient has symptoms of esophagitis, because PPI can is known to halt or decrease the Barrett's, and you treat for the GERD if the patient has erosive esophagus. If you find dysplasia or the Barrett's is gradually progressive on sequential scopies, you can try endoscopic ablative therapy. Well, the ideal endoscopic ablative therapy is that it inflicts injury deep enough to destroy all the epithelium, but not deep enough to cause complication. Well, this you can't have the best of both worlds, right? So none of the ablative therapies available so far has achieved this goal. Many have been tried, but only few have been tested. What is being done in few centers is the photodynamic therapy, the radio frequency ablation, and the RFA. The RFA that is used in various modalities across the body now is the same principle, radio frequency ablation of the tissue. You can use cold or cryo ablation. Again, the principle is to ablate the tissue. The disadvantage, as mentioned here, is it cannot give you the histopathology. Sometimes it leads to burying of the metaplasia rather than destroying. And what we are worried about is serious adverse events like strictures. EMR or endoscopic mucosal resection, yes, this is one thing which is now practiced, and it can be where you can remove the tissue en bloc or in tissue in pieces, provides tissue for histopath, which is the biggest advantage. There is less risk of a stricture formation for the patient as compared to the ablative therapies. And there are 2 types of techniques endoscopically, suck and cut and the band and snare. This is just the image of how you would normally do a EMR, the band, suck and band technique, and suck and cut and the band technique, and where you the cartoon, the image in the bottom image shows you how tissue would look like, or the esophagus would look like after the EMR has been done. What is important in Barrett's, this is just the last slide, I'm coming to the end, is once you detect Barrett's, and if you have not done any therapy, or if you have done therapy, how do we go about? Well, we know it is a pre-malignant condition, so these patients have to be put on follow-up similar to what you would do in a CRC. However, various guidelines, various societies have their own different guidelines. What we normally follow is that if the first extensive biopsies don't show dysplasia, then the next endoscopy would be done at 3 to 5 years. However, if you find low-grade dysplasia, what is recommended is to do a repeat biopsy on treatment after 6 to 12 months. And if it still shows, then consider one of the endoscopic eradication techniques. If there is high-grade dysplasia confirmed by the pathologist, then you have to straight away take the patient for either RFA or a mucosal resection, and that you have to do preferably unless it's an advanced malignancy, and these patients should not just be put on plain surveillance. So where there is high-grade dysplasia, some form of therapy has to be offered to these patients. This is what normally we follow. It's an amalgamation of all the 3-4 guidelines that is done. I think this is the, this was the last of my my slides. Thank you.
Dr. Rajesh.
Hey.
Yeah. Thank you so much, Dr. Meghraj. That was a lovely lecture. It practically covered, it's a vast topic. I know GERD by itself, as you have already said, there are books written on it, as well as the other topics. For the sake of our PGs, can I ask you one or two questions?
Yes.
Is there any overlap between GERD symptoms and that of IBS? I mean, as a clinician, if they are going to see these patients.
Okay. Sir, there is a section of esophageal disorders where we call as functional esophageal disorders, where these are patients where based on the impedance, you don't document any acid reflux in these patients, but these patients have what we would call as the hypersensitive or sensitive esophagus. Such category of patients can have other functional GI disorders associated, like a gastric motility disorder, which or what we call occasionally a postprandial distress syndrome like thing, or a gastric motility problem, or an associated IBS. So it can be associated with the functional esophageal disorders. Again, a condition which is not very easy to diagnose. You have to actually do manometry, including the pH, to diagnose that there is no acid or volume reflux happening in these patients.
Perfect. Can we use manometry to kind of pick up which patient is going to be suitable for which kind of hiatus hernia surgery?
Yes, right? I think the surgeons would agree with me that before any hiatal hernia surgery is done, most surgeons would want to get a manometry done. One, to confirm the hiatus by the changes in the levels of the pressure, and also to confirm that the lower esophageal is normal in these patients, because then that can be detrimental if there is significant ineffective lower esophageal motility before we doing, because patients occasionally can complain with significant dysphagia once you have repaired the hiatus. So yes, manometry plays a big role in deciding patients to be taken up for surgery, and patients should actually might not do so well with surgery.
It may also be used to document how the patient has responded to therapy later on. I mean, patient may still come back to you complaining of this.
Please excuse me to interfere. It is 9:46. I think we should take the next talk. Otherwise, the last speaker suffers a lot, you know.
Okay.
I know.
Thank you so much, Dr. Meghraj.
And I have been there as a last speaker waiting for a talk to start. So I understand that.
So,
thank you.
Any other further questions can be put on the chat and can be.
I think it can be answered.
Yeah.
Thank you so much, Dr. Meghraj.
Okay. Now I will introduce Dr. Anil Gvalani. Now Anil Gvalani, one of the senior most person at Nair Hospital, being the head of the department and KEM, and now he is joined as a professor of surgery at DY Patil Hospital. And of course, all undergraduates, even including the postgraduates, must have read his book also, a surgical book by Gvalani. And a very humble person. He's my batchmate, to be very frank. And now I'll hand over to Dr. Gvalani. Please.
Yeah. Thank you, Kamlesh. It's such a pleasure to see you and to be with my batchmate.
Okay.
I will start and I will share the screen. My talk will be in two parts. One is the video of the colon replacement, and the other is a PowerPoint presentation. So first I will start with the, is it visible?
Yes, sir.
Yeah. So I'll give a running commentary. First, I'm showing you the patient who is eating his first meal after a successful colon replacement. He's still skin and bones, you can see the colon, which I usually keep subcutaneous. So even the peristalsis can be seen. And he's eating two of the difficult things to swallow, that is idli and sandwich, for a colon to transmit that. So this is one patient who is eating something. And another patient, this is 2 years follow-up. You can see he has put on good weight. In fact, his colon under the skin is hardly visible. And he is also able to eat normally or as normal. This patient's upper GI Scopy I did and recorded it. And it gives an unusual experience of a colonoscopic field. We are going through the colon from the mouth, then entering the stomach, and then seeing the pylorus and the duodenum. I mean, it's just a unique feeling for the endoscopy. So on withdrawal, we can see that in this patient, the vocal cords are moving well. Now, this is another patient, a female patient who's got a long corrosive stricture, and her operation, in short, I'm going to describe or show. The operation is about to start. The previous scar is being excised. We are looking at the adhesions inside. And most important thing is, of course, to get full mobilization of the colon. So we are looking at the mess which is already created with prior intervention. So some adhesiolysis is being done. And after that has been achieved, then the colon has been mobilized completely. And now we are looking at its blood supply. This is the most crucial part. For a successful result, we want a colon. I'm tracing the marginal vessels of the colon, right from left side of the colon, sphenic flexure. This is now going to show the middle colic. And that is the pedicle on which I will place the graph. And this will show the right side of the colon with the right colic and the ileocolic vessels. So this thorough mobilization is absolutely essential to get adequate length. Now I clamp all the blood supply except the pedicle and wait for 10 minutes. Afterwards, when I see the colon is all right, that is when I will start the transection. So this is the cutting of the colon towards the sigmoid colon side, the distal part. And as we can see, the blood supply is good at the cut margins. So it's a very heartening thing when on dividing, you find a spurter, as we will see. This is the colon being divided on the side of the hepatic flexure. And what is important to note is that it's got a good blood supply. It's only relying on the middle colic. All other vessels have been disconnected. That's again to show the colon length with its blood vessels, and it is viable. It has to remain viable till we bring it in the neck, and of course it will remain viable forever. Now the colocolic anastomosis is being done by the usual method. So that's nothing big or great about it. We are maintaining the GI continuity. That's just checking the colocolic. Then I go to the neck and dissect the neck, and it's a hockey stick incision going layer by layer, ultimately tracing and identifying the esophagus. The thyroid lobe comes in the middle. We just find a way to go around it, and we identify the esophagus, and we will loop it. Now this is the esophagus in the neck which has been looped. Now this, I divide it completely. There are some people who do end to side, but that doesn't work that well. So the esophagus is divided, and the lower end is sutured closed forever. And I dissect further down towards the mediastinum so that I get extra length of esophagus in the neck. Now this is the colon, which is still alive. I mean, yes, the patient is alive and fine. She had visited the OPD very recently, and she was eating, what should I say, groundnuts and peanuts in the OPD, you know. So anyway, so this colon is okay. Now I prefer the safest method, and that is subcutaneous. I know the drawback is the cosmesis, but I feel that is less of a problem than the problems when you place the colon in some other planes. So adequate mobilization, adequate space being created, antisternal or subcutaneous. The colon is in the hand. It's still all right. And then I'm ready to transfer this lower end of the colon up to the neck. So once more, I like to cross-check that everything is fine. And my technique is that I bring a sponge holding forceps, from above. It's in my control. I open it. I put the ends of the colon, which have to go up. Just hold them in the jaws. Mind you, it is not at all close. It is not crushing, not at all. It's just a grip. And it is not pulling as much as I am pushing. I'm pushing from down, and it is just walking its way from the space adequately created. And there the colon has reached the neck. Release the sponge holder, no instrument wanted. Now again, your fingers are the safest dissection. You readjust the position of the colon, and that is possible. And now we have a situation where the colon lower end is in the abdomen, upper end is in the neck, and the upper end is now going to be sutured to the cut end of the esophagus, end to end. Mind you, there is a big disparity between the diameter or the circumference, but we have to do it. We have no other alternative. So esophagus being sutured to the colon, as you are seeing, the stitches are being removed and everything is okay. The tinea coli appendix is okay. I do not sacrifice. They carry important blood supply. So after this, the neck will be closed with a drain. And now the last part of the major anastomosis, and the colon being anastomosed to the anterior wall of the stomach. So wherever it is lying comfortably, that's the place stomach is open, and a standard anastomosis performed. As you can see here, colon with the stomach. And of course, the feeding jejunostomy is must. Closure of wounds, drains. This is a picture. Now, this patient, about 8 to 10 days post-operatively, I did a dynamic by barium study. There's always a controversy that the barium goes down by peristalsis or it goes down by gravity. Now, you look at this picture and decide for yourself what is happening. Look at that barium walking its way. Ryle tube is still in the position. I removed the Ryle tube only after a gram has shown that it is all fine, and there it has entered the intestine. Now, this is I asked the patient to say something. So this small study, I've even published it in the Indian Journal of Surgery. And that's the operation I wanted to show. And I will stop this. And I will go to the PowerPoint presentation. So yeah, is it visible?
Yes.
Yeah.
Yeah,
okay.
Yeah, visible.
So now let us learn a little bit of theory of corrosive problems in the esophagus, especially for the PG students. So corrosive ingestions are a serious health hazard. I'll just minimize this. Yeah. And it is shocking to know, I mean, we don't have Indian statistics, but in a country like USA, can you beat it? 5,000 cases occur every year, and that's the lowest figure. It's 26,000. That's the range. My God, unbelievable, isn't it? And how do this? What are these corrosives? They are the household cleaners, and 75% occur in children, 25% occur in adults. Very rarely there is a case of homicidal, which is there in my series. One patient, somebody had tried to, his friends, so-called friends, had tried to kill him by forcing acid down his mouth. Corrosives are a group of chemicals that cause injury. So that's like basic understanding on contact. Now, this is something that I want to share with all the PG students and all those who would like to embark on this kind of surgery. This is the standard anatomy of the colon with the standard blood supply. I mean, this is what is ingrained in our mind, that there is a right colic, there is a ileocolic, there's a middle colic, and there's a left colic, and then there are the sigmoid branches. But just like in the laparoscopic cholecystectomy or in cholecystectomy, you must know that the normal anatomy is present in only 50% of cases or something like that, or 60%. So expect some kind of an abnormality, and that is what would guard you to make your cholecystectomy a safe one. So same thing is related to the colon. Colon, when we are doing a colectomy, we are not bothered. we are removing. But when we are saving the colon, we have to know whether the marginal artery is continuous. So usually marginal artery is very reliable, but the venous pattern is dangerous. Remember that. Venous pattern can defeat you. One variation is there is no ileocolic and right colic marginal vein. Second, no right colic to middle colic marginal vein. And third, no middle colic to middle colic marginal vein. So this is one dangerous thing. Now, the second one, the normal anatomy is present only in 68%. So if I round up the figure, 70%, 70% are the cases where we see the normal anatomy of the arteries. But in the remaining, I went to one slide further. But in the remaining, this is the thing, about 12 to 13%. Now, these are the permutation. Now, see, these are two middle colic arteries. I had one patient in my series where I had to save both the middle colic. So that made a job a little different. Now look at this. This is the most dangerous for those people who are mobilizing the graft on middle colic. This is action middle colic. So then you have to have other alternatives in your mind. Now, I won't bore you too much with this, but this is what the literature shows, that this is a type 4 variation, type 5 variation. It's a kind of a busy slide, type 6, a little scary that so many variations are there. And if you are not aware that in type 7, the middle colic is actually supplying the left colic. So, I mean, if you're mobilizing the colon on the left side and you sacrifice the middle colic, you could be in trouble because you have knocked out certain important blood supply. So that is something we should have it in the back of the mind. Coming back to what are these corrosives which are commonly found? They are the acids and the alkalis. They are the drain cleaners, or the toilet bowl cleaner, or the hydrochloric acid. One of my patients, he used to ingest nitric acid because he had a small jewelry shop in Malad. And in jewelry or in cleaning of the jewels or diamonds, they use nitric acid. So he had an access to nitric acid. Now, burns with alkalis, are they more dangerous, or burns with acids? The alkalis are more dangerous because they liquefy. Liquefaction necrosis means it goes on burning deeper and deeper. Acids cause coagulative necrosis. So to some extent, it controls. How soon we can do an endoscopy? Of course, we can do as early as within 1 day. Then this is the classification of corrosive burns on endoscopy: grade 0, 1, 2A, 2B, and grade 3. What can you do is like a first aid. I mean, if you are present when this accident has happened, well, if you know what he has ingested, you could try the antidote. So for alkali, it would be like orange juice. For acid, it could be milk. Do not initiate vomiting. Do not. How often can we do? Please remember, no organ can replace the original. So the esophagus is the best organ for the esophageal function. So at all costs, it is a correct thing to save that esophagus and solve the problem of corrosive strictures by esophageal dilatation. So that is the mainstay, esophageal dilatation, nothing like the original. But the cases which get referred to me are those where that modality of treatment has failed. So when that has happened, I am treating a patient with an end-stage esophageal disease, and I need to replace. Now, theoretically, you can use this 3 small intestine, large intestine, and stomach. But esophagus, long segment, the small intestine, jejunum is out of question. So the race is only between colon and stomach. Now, emergency care, don't induce vomiting, don't perform gastric lavage, treat the shock if patient is in shock, then of course the oxygen ventilation. If the patient has all settled down on anything, whether it is esophageal dilatation or whether it is a colon replacement surgery, of course psychological counseling, because most often etiology is suicidal. No, not most often. Most often is accidental. Second common is suicidal. So to correct that aspect, we would require the help of the psychiatrist and a long-term follow-up. So this is the thing. before I go to Achalasia, Cardia, one more thing that how do we decide whether to use stomach or whether to use a colon? Now, stomach can be made into a tube, but usually the burns have already burnt the stomach. So that is one reason why stomach is unsuitable. Second, the patient has already been operated by some other center and a feeding gastrostomy done or a gastrojejunostomy done. So that takes away the possibility of stomach. But supposing there is a case where stomach is still kind of normal, virgin, and we can use it. My take is that to create a new esophagus, we are sacrificing the physiology of stomach. So when you are converting the stomach into a tube and making it to function only like an esophagus, you are sacrificing the normal gastric physiology. So we have colon, and I would personally prefer the colon than to damage stomach to make it into a tube. That's just my personal take. So now I come to the third part of my talk, and that is Achalasia, Cardia. This is more for the, say, PG students or undergraduate students. Achalasia, the definition is enormous dilatation due to functional constriction at the cardiac end. It is a motility disorder, loss of ganglion cells. The esophageal peristalsis do not coincide. In fact, the lower esophageal sphincter does not relax. It is common in females, common in this age group, and common in individuals with stress, emotional stress. There is something known as an epidemic variety, Chagas disease, due to trypanosomiasis. It can also occur due to vitamin B1 deficiency. On gross, the esophagus is markedly dilated, tortuous, hypertrophy, smooth narrowing. On microscopic, there are chronic features of chronic esophagitis. On manometry, we find, and that is the diagnostic, and there are kind of three variations: no contractions at all, pressures there, but not passing across, high pressure, but still not having peristaltic activity. The clinical features, dysphagia is more for liquids than for solids, foul smelling regurgitation, repeated attacks of respiratory tract infection due to aspiration. Plain X-ray chest abdomen is widening of mediastinum and absent fundic bubble. Barium swallow is one of the diagnostic thing, and that is the bird beak appearance. The bird beak appearance, which some amount of peristalsis can be induced on injection of carbachol, but it is still incoordinate. Esophagoscopy is very good. It is like the classical description is you have entered a cave, widening of esophagus, foul smelling, aspirate, and multiple mucosal ulceration. And of course, the diagnostic is the manometry. Now, the complications are esophagitis and this and aspiration, pneumonia, and so on. But the prognosis is not bad. It is good because we can treat it. And how do we treat it? Pneumatic balloon dilatation, surgery, the gold standard, Heller's esophagocardiomayotomy. Today, these two in competition, we have POEM and botulinum toxin and drugs. These two are inferior to the above three. And the more popular one, going in a chronological way, dilatation, forceful dilatation. The success rate is up to 85%. But the biggest problem, complication that we are worried about is that I know there are safe balloons available, but there is always this risk of a perforation. Heller's myotomy, in the olden days, we used to do it open. Today, it is laparoscopy. The success rate is 90%. It can also be used after a failed balloon dilatation. Now, there are two main controversies. What should be the length of myotomy and whether anti-reflux procedure should be performed? So let's take first one. The length of esophageal myotomy. On the esophagus, what is recommended is 6 to 7 centimeters above the GE junction. The controversy is how much we should do distally. Some authorities prefer up to this level, 1.5 or 2 centimeters. And some authorities prefer 3 centimeters. The 3 centimeter people, this is advocated because it results in less of dysphagia. So this causes a better result. But when you do a long myotomy on the stomach, then the reflux is a big problem. Now coming to the anti-reflux procedure independently, There are surgeons who do Heller's esophagocardiomyotomy and would not put any anti-reflux procedure. This is also there in the literature and the results are good. But majority of the surgeons, we are always comfortable, and especially when we have taken a long myotomy on the stomach, we are going to perform an anti-reflux procedure. Now the controversy or the thing is, shall we do an anterior door or a posterior toupee? This is an anterior door. This is laparoscopically more popularly performed, and it gives the added comfort to the surgeon that if at all there has been any breach in the mucosa, the serosa of the stomach will cover it up. So this is a more popular one, anterior door fundoplication, and it works well. But let me describe the other one, because according to one school of thought, the posterior toupee is a better one. Now, when you do a posterior toupee, it's clinically or technically a little more difficult. But when you suture the edges, the advantage is that the myotomy remains open. And according to this school of thought, this is a better option. Anyway, surgeons' choice it is, whatever they would like to do. Endoscopic myotomy is the new one, which is giving a big challenge to both these procedures because the results are comparable. The results are comparable. So that's a very good procedure. The botulinum toxin, this is not permanent and it needs to be repeated. And repeated injections can make future operation, if the patient requires, the operation little more difficult because there is fibrosis or there could be more element of perforation. And these are the drugs which have been used. They work, but they are not like a permanent solution. So I think I end that. And as Kamlesh pointed out, I have some books in the market. So at least for the PG students, if they want, they can use and make help of it. Thank you.
Thank you, Dr. Gvalani, for your nice lecture and a demonstration of a surgery, which was really a very challenging surgery. I know, and you are very much interested from our Nair days only, and you are performing this surgery in multiple number of patients. Now, one question from my side.
Yes.
Now, what about this anomaly of the blood vessel? Yes. Whether you do angiography pre-operatively or on table you take a decision?
On table. Angiography is of no help.
Yeah.
On the table, mobilize the entire colon, do transillumination, and you will see the wonderful blood supply.
Absolutely. That's what I wanted to send a message. It is not an angiography which is going to tell you. It is always on table decision what you are supposed to see. Now there is a question from audience.
Yes.
What is the incidence of a cardiac arrest while performing an esophageal dilatation for a stricture?
I think our medical colleague will be in a better position to say that. No, esophageal dilatation is a very safe procedure. I don't know why he's thinking about a cardiac arrest.
I know. I don't know. You must have come across or you must have heard.
Yeah. No, esophageal dilatation is absolutely safe. Absolutely safe. There is no problem. It is the treatment of choice. Ureter stricture, ureter dilatation. Esophageal stricture, esophageal dilatation. Nothing like it. But only sometimes maybe some immature or amateur endoscopists may try and push and dilate a stricture which is and create a perforation. I mean, some cases have got referred to me at that stage, but still there is no cardiac arrest. I mean, I have been able to go down and do whatever corrective measures that were required to be there. So esophageal dilatation is perfectly safe, dear. Absolutely.
Yeah. I think most probably it may be some event which must have occurred in one or two patients.
Coincidence.
And because of it is a coincidence.
Yes.
Now, any other question from any of the panelists or even Sanjay? Yeah, please.
I am Abhay Dalvi.
I know.
Hi, Abhay. Hi, Abhay. Put your camera on. Let me see you here.
No. Let me be behind the scene. It's a Friday evening, so it's not the thing. I just want to tell the audience something from my heart. Dr. Anil Gvalani, as I worked under him, when he joined KEM as a HOD, saw his commitment to esophageal strictures and colonic replacements. He has this passion for doing this surgery and has been recognized by not only Maharashtra State Chapter in his lecture in Solapur, as well as ACRSI in Dubai. I'm fortunate to have been a contributor to authorship to the publication in Indian Journal of Surgery, and also refer patients to him from my OPD after he went away. I have sent him 2 or 3 patients to DY Patil saying that it's not my cup of tea. And if at all somebody in Mumbai or maybe Maharashtra can do this sort of surgery, it's only Anil Gvalani that can do it. I remember one patient from Nanded whom Dr. Gvalani operated, and that Nanded patient may not be phoning Gvalani so often, but keeps on phoning me that you directed me to the correct person and that she is swallowing so well. So
yeah, she is the same operation I showed. Vanisha Godane. Yes.
Okay. I don't know which operation you showed, so I'm just trying
same
to
one. Yeah. Yes, true. She is the one who came to DY Patil OPD, and believe me, I could not recognize her because she was well nourished now. She was sitting on the bench with one foot on the seat, okay, and eating apna chana and peanuts. I tell you, I was surprised myself. So yeah, she's in touch with me. Yeah.
Abhay, so nice of you to come in between and chip in. It sends a message. See, you should know your limitation. And if you know someone who can do a good job, kindly refer the patient, send to the best of the person, which is not done very routinely or commonly by rest of the people. I think this is a very good message by our president of ASI. And I'm so nice, Abhay, to you chip in and give us this information.
It is so sweet of Abhay, dear.
Abhay,
so sweet
really.
of you to. Thank you.
Now, Sanjay, please take over and introduce Dr. Suraj.
Can I request Dr. Suraj Pawar, who is the surgical oncologist at Kolhapur Cancer Center. He is going to present on robotic esophagectomy. Dr. Suraj.
Every time this happens.
Pardon?
Hello.
Hi.
Yeah, so thank you very much. Is my presentation on?
Yes.
Yeah, okay. First of all, let me thank the Mumbai Surgical Society, as Dr. Gvalani and Dr. Kamlesh sir mentioned. They have been classmates, and so also I've been classmate with Dr. Niranjan Agarwal, thanks to him, my dear friend, and also great to have Dr. Abhay Darvi sir, who has been our teacher at KEM Hospital. And I know it's pretty late and we are behind schedule, so without further ado, let me just start this presentation. It's not just robotic esophagectomy. This talk is on CA esophagus management. It's a huge topic, but I'd like to try to cover it as fast as possible. Just a minute, the slide is not moving. Yeah. So if you look at the incidence, this is our own publication in IJMPO. The esophageal cancer worldwide incidence is 5.7 lakh new cases per year, 52,000 in India. And at Kolhapur Cancer Center, we see around 163 new cases per year. And as per the WHO, esophageal cancer is the 6th most common cancer, 5th most common cancer in males, and 6th most common cancer in females. If you look at the etiology, tobacco, alcohol, betel nut, we all know about all these things. Just give me a minute. I'm just trying to adjust my screen because I'm not able to see the top thing. Sorry. Okay. Obesity leading to GERD is a risk factor, Plummer-Vinson syndrome, diets low in fruits, vegetables, and excess of nitrosamines like pickled vegetables, cured meats, and fish, and hot beverages, soup, physical irritation due to loss of teeth, poor oral hygiene, and there are some hereditary syndromes as well. Now, if you look at the symptoms, the most danger sign is the dysphagia. So more than 90% of the patients that come to us with cancer esophagus have dysphagia as a presenting symptom. Odynophagia, weight loss, and then hematemesis, hemoptysis, melena, dyspnea, and persistent cough in advanced cases, dysphonia or hemidiaphragm paralysis because of involvement of the recurrent laryngeal nerve, again in advanced cases, SVC syndrome, Horner syndrome, abdominal pain, and back pain are some of the symptoms. Uh, if you look at the workup, history, physical examination, of course, upper GI Scopy and biopsy, CT scan of the neck, thorax, and abdomen, bronchoscopy in selected cases where is the middle third lesion and it is impinging on the trachea or the bronchus, then in such cases we will do a bronchoscopy. PET scan is done whenever it is possible because it has been noted that PET scan can upstage the disease to the tune of almost 12%, thereby meaning that if you have planned a surgery in a patient and you do a PET scan, the plan of surgery would change because of the upstage of the disease in around 10 to 12% of the cases. Endoscopic ultrasound, all these investigations basically to accurately stage the disease for proper planning. Nutritional assessment and improvement is a very important thing because most of these patients are highly undernourished and they need a nutrition plan, and of course tobacco de-addiction. Now, these are the different stages. If you look at the very early stage, the TIS in situ, T1A, limited to the mucosa, these are the patients who would go for endoscopic mucosal resection or endoscopic therapy. But anything beyond T1A, T1B involving the mucosa, T2 involving the muscularis propria, T3 going beyond the muscularis propria, one must understand and realize here that the esophagus does not have a serosa. So directly from the muscularis propria, it can go outside the esophagus. T4A is extending outside the esophagus, involving the surrounding structures like the pleura, the adventitia of the aorta or the pericardium, still operable. Up to T4A, it is still operable. But beyond that, if it's T4B, which is infiltrating the aorta or infiltrating the vertebral bodies or infiltrating into the trachea or the bronchus, then it clearly becomes an inoperable case. These are to show just the stage correlates with survival. Early stage survival is very good, around 40-45%, and in the higher stages, it is very poor survival. If you look at the histology, the most common in our country is the squamous cell carcinoma, eastern part of the world. Adenocarcinoma is more common in the western. These are some of the other rare variants of histology. So if you look on your left side, adenocarcinoma is more common in the western world, northwest Europe, East Europe, North America. Majority of the cases in the western part of the world are adenocarcinoma, whereas China, Southeast Asia, India, the most common histology is squamous cell carcinoma. Now, these are the NCCN guidelines as far as the management is concerned. As I mentioned earlier, carcinoma in situ, PTIS, limited to the mucosa, endoscopic therapies, endoscopic resection, ablation. These are the choice of treatment. But anything beyond that, anything beyond T1A, T1B, up to T4A, esophagectomy is a treatment of choice. But before that, now there's more protocol that before going ahead with upfront surgery, there are newer adjuvant therapies that are coming up. So as I mentioned earlier, in early cases, endoscopic therapy, I'm not going into the details, it's already been, the talk been covered. These are the various methods of endoscopic mucosal resection. And more advanced cases, T1B, T2, T3, T4, high risk, esophagectomy is a treatment of choice. But majority of the patients, they undergo preoperative chemoradiation followed by surgery. There has been a very historical trial, which will come to that very soon. So rather than going for upfront surgery, we give neoadjuvant therapy, downstage the disease, and then operate. Anything about T1A, that is T4B, anything about T4A. T4B is definitely inoperable, as I mentioned earlier. So the treatment of choice is chemoradiation or palliative management in the form of either stenting or similar other procedures. So if you look at the overall picture, surgery is the treatment of choice. Neoadjuvant radiation therapy followed by surgery is an option. Chemotherapy followed by surgery is practiced in several centers, especially in Japan. But the standard guidelines of what is more promoted now is chemotherapy plus radiation therapy followed by surgery. This is now the report showing gives the best possible results. And this is the historical cross trial which has analyzed chemo radiation followed by surgery. So they analyze, this study is coming from Amsterdam. They analyzed 368 patients, 188 patients in surgery alone group, and 180 patients in neoadjuvant chemoradiation followed by surgery. And they have shown a survival benefit with the chemoradiation followed by surgery as compared to surgery alone. And this forest plot also shows that subgroup analysis, they are more in favor of chemoradiation therapy followed by surgery. This is the survival chart. It shows that the median overall survival with neoadjuvant chemoradiation followed by surgery is 48.6 months as compared to surgery alone. So there's a significant difference in the survival neoadjuvant therapy followed by surgery versus surgery alone. And this is a historical study which has led to a total different plan in the management of cancer of the esophagus. This is our own data coming from Kolhapur Cancer Center, published in SAGC, where we analyzed 157 patients who underwent neoadjuvant chemo radiation, and we found out that the pathological clinical response was found in 40% of the patients. And these are the good prognostic factor patients, meaning if you have a pathological complete response, then the results are much better. The patient still will undergo a surgery and they have a better survival. So surgery is the treatment of choice for the cancer of the esophagus, although it has a very high morbidity and mortality. And if you look at this, a very complex anatomy, esophagus lying in the posterior mediastinum, surrounded by the trachea anteriorly, the vertebra posteriorly, the arch of aorta, azygous vein, the recurrent laryngeal nerve, thoracic duct. In a very, very small space, very important structures are there. And as I mentioned earlier, there's a level 1A evidence that surgery still as of today is the treatment of choice. Now the NCCN guidelines for principles of surgery, they say that the type of esophageal resection is dictated by the location of the tumor, the available choices of conduit, as well as the surgeon's experience and the preference of the patient. In patients who are unable to swallow well enough to maintain nutrition during induction therapy, esophageal dilatation or a feeding jejunostomy is preferred. Take-home message here is gastrostomy should never be done because subsequently you are going to need the stomach to make the stomach tube as a neo-esophagus. So the take-home message for here to the students here is, in a case of cancer esophagus, if you have to do a feeding tube insertion, you can do a feeding jejunostomy, but never a feeding gastrostomy. So these are the various surgical options historically: the segmental resection, Garlock's approach, the Ivor-Lewis procedure, laparotomy and right-sided thoracotomy with intrathoracic anastomosis, the McKeown 3-stage total esophagectomy with anastomosis in the neck, the transhiatal esophagectomy, then came the more radical procedures, the 2-field esophagectomy, the 3-field esophagectomy, which is very commonly practiced in Japan and a few centers in India, including our center. And then came the minimally invasive, the VATS procedure, video-assisted thoracoscopic surgery, or the thoracoscopic esophagectomy. And the most recent addition is the RAMI, robotic-assisted minimally invasive esophagectomy. So the acceptable conduits are, of course, the most preferred is the stomach, which is the most robust. In case stomach is not available, then the colon or the jejunum can be used. Acceptable lymph node dissections are the standard or the extended 2-field or 3-field lymph node dissections. And the patients who are undergoing esophagectomy without induction chemoradiation, the acceptable number of lymph node dissected are a minimum of 15 lymph nodes should be removed so as to achieve an adequate staging. One must understand the esophagus has a very extensive lymphatic drainage, very rich mucosal and submucosal lymphatic drainage, so there can be skip metastasis, and hence these are all the lymph node stations that have to be removed as per the Japanese Esophageal Society classification. We have the mediastinal, the abdominal, and the cervical lymph nodes, which have been mentioned here. I'm not going to the details, but all these lymph nodes have to be removed. Now coming to 3-field esophagectomy, which was is the most radical surgery for esophageal cancer in view of the extensive lymphatic drainage, Lymphatic drainage is not always systematic. They can be skip metastasis, and failures are more loco-regional rather than systemic, and hence it's important to achieve a complete radical clearance. Now, this article addresses the three-field lymph node dissection in esophageal cancer, and they have come to the conclusion that although multidisciplinary treatment has improved the prognosis, it is commonly associated with worse prognosis. And the three-field lymph node dissection, this procedure was established way back in the 1980s in Japan and is currently widely accepted throughout the world. And there are various studies showing the superiority of three-field over the two-field. However, there are very few prospective randomized control trials that have compared two-field versus three-field. In fact, I'm aware of one such study in process at the Tata Memorial Hospital, and we are waiting for the results, whether a three-field is really superior to two-field. But by and large, as of today, a two-field lymph node dissection or an extended two-field in view of the neoadjuvant chemoradiation is an acceptable standard procedure. Then came the role of minimally invasive surgery in surgical practice. We all know it has reduced large incisions, reduced post-operative pain, early mobilization, shortened hospital stay in all minimally invasive surgeries. But whether minimally invasive surgery can play the same role in esophageal cancer, because it is not just a minimally invasive approach, but the extensive dissection in the mediastinum and the abdomen. So whether it can really play a role. So minimally invasive surgery was first reported in 1992 by Kusheri et al., where they performed this kind of a procedure. And these are the various studies in literature. The largest study is by Smithers et al. For 46 cases. The second largest is 222 cases by Luketic. And the third largest is our series, which has been recently published in SAGC, 214 cases where we have developed our own technique in the semi-prone position. So the concerns with minimally invasive surgery is regarding the morbidity and about the oncologic radicality, whether it can achieve the same radicality as compared to the open procedures. And it has been shown that the pulmonary complications in minimally invasive surgery, the restrictive lung damage is less, the pulmonary function is better, and the reduction of vital capacity is less with minimally invasive surgery. As far as the oncologic results are concerned, they are comparable with open surgery. Smithers have shown that 5-year survival is around 40%. So also Luketic, and they have shown a similar, equally good survival as compared to the open surgery. As far as the oncologic results are concerned, in lymph node negative patients, the 5-year survival is similar, thoracoscopic versus open. Lymph node positive patients, again similar survival, thoracoscopic versus open, as shown by Osugi et al. Similarly, in T1, T2, and T3, T4 lesions, you can see the 5-year survival is similar, thoracoscopic vis-a-vis open surgery, as shown by Osugi. So, is minimally invasive surgery beneficial? Meta-analysis, it has shown that it is safe alternative to open technique, and patients may benefit from shorter hospital stay, lower respiratory complications, lesser morbidity compared to open esophagectomy, but a multi-center prospective study is necessary. So to brief up, minimally invasive surgery does in esophageal cancer lead to shorter hospital stay, lesser blood loss, less pain, lesser pulmonary mobility with no oncological compromise. So there's definite advantage of minimally invasive surgery. Now, these are the two standard approaches in literature in minimally invasive surgery. The lateral approach has been propagated by Law et al., Kawahara, Osugi et al. And the other one is a prone approach propagated by Kusheri, our own Dr. Palnivelus, Smithers et al. But these two approaches have their own limitations and their shortcomings and advantages. This is a lateral approach where the surgeon stands on the back side of the patients. There's one assistant on his left side. There are 2 more assistants on the front side, and 3 or 4 ports are required, maybe a mini thoracotomy. So there's a big team working, and it has to be a teamwork. It makes a job a little more messy. And you're standing with your hands abducted and a little cumbersome for the surgeon as well. In the prone position, these things are avoided. However, the biggest disadvantage in the prone position is that in case you require an emergency thoracotomy, it can be time consuming. You have to de-strap the patient and turn him in the lateral position to do a thoracotomy, and it can be, in emergency, it can be a big problem. So we at Kolhapur Cancer Center devises our own innovative technique. It is said that the necessity is the mother of invention. So in our center, the 3-tier city, we didn't have very highly qualified assistants, shortage of highly trained staff. So we came up one fine day, we stuck with an idea of why not to combine the advantage of the lateral and the prone approach. So we came up with a semi-prone approach, the Pawar technique, and this is how it is. The patient, the semi-prone position, 45 degrees and inclination anteriorly. And instead of standing on the back side, the surgeon is standing in the front side with just one assistant, only 3 ports. Both the team is looking in the same direction, the monitor, and this we try to simplify the procedure. Here you can see the camera port is going through the center and the 2 operative ports. Just a team of 2. This is a video of semi-prone position, the Pawar technique that was presented in the best video category in the SAGES World Conference in Washington, where Dr. Abhay Dalvi was also there in the same conference in the year 2010. So I'll quickly rush to this video. This is the position, lateral position, patient tilted anteriorly by 45 degrees. And then we take the 3-port approach. You can see here the posterior axillary line. To the mid-axillary line goes the camera and the 7th intercostal space, and 2 operating ports in the 5th and the 9th intercostal space, the camera in the center, and the 2 operating ports, and just one assistant holding the camera, and both of us are looking in the same direction, which makes more. Now we are in the mediastinum. That's the Oesophagus vein here. The dissection starts in the infraoesophagus region with the harmonic scarpel. This is the Oesophagus vein here. That's the vertebra. This is the aorta. And that's the esophagus here. I'll fast forward the video because of the constraints of time. But what we do is we preserve the Oesophagus vein. We put a pneumo of 10 mmHg into the chest. I can hear some voice from the other side. Can somebody mute?
Kuldeep, mute the others. Kuldeep, mute all the others.
So this is the aorta here. And as the esophagus being pulled down, we put a high pressure pneumo of 10 mmHg. This is again for the first time we demonstrated that you can have a high pressure into the mediastinum without any problems. So that's the left pleura. All the fibrofatty tissue has been dissected towards the esophagus. And that's the aorta. You can see here we are dissecting in the plane between the aorta and the esophagus posteriorly. To your right side is the head end of the patient. To your left side is the diaphragm. And this is the right lung. Whatever is coming towards you is the right side. Whatever is going away is the left side. So this dissection you can see because of pneumo, the planes are opening, and with the use of the harmonic, it is almost a bloodless field. I will fast forward. We are going lower down. This is the diaphragm. That's the right crust of the diaphragm that you just saw. And on the opposite side, this is the left crust of the diaphragm. This is the hiatus you see from the top. This is where we stop the dissection, and the entire esophagus is dissected along with the lymph node. Then we come anteriorly in the plane between the pericardium and the esophagus. So this is the avascular plane you can see here, and that's the left vagus coming in view, which is divided lower down. This is the pericardium, and this is the left vagus, which is divided lower down after it gives the tracheobronchial branches. And you can see all the pericardial group of lymph nodes have also been dissected. Again, I'll just fast forward. So these are the, again, we are going up. These are the subcarinal group of lymph nodes. You can see this is the right bronchus. That's the left bronchus here. That's the esophagus that is lifted up. And the subcarinal group of lymph nodes are dissected, which is a part of the radical dissection. Here you can see we are near completing the subcarinal group of lymph node dissection. And this is the right bronchus, and these are the subcarinal lymph nodes that are being cleared. Here you can see all the clearance is being done now. So this is the inferior pulmonary vein. That's the left bronchus, and these are the lymph nodes in the aortopulmonary window. I will show you the arch of aorta coming over there, so that the aortopulmonary window is also completely cleared. So you can see the left bronchus. That's the arch of aorta, and this is the aortopulmonary window being cleared. This is the inferior pulmonary vein. And you can see you get the best view of the entire anatomy because of the semi-prone position, which is a little difficult in the lateral position or the prone position. So this is the technique that we divide in the year 2007. And now the esophagus is lifted up. You can see the pericardium. This is the inferior pulmonary vein here. And that's the aorta. So we have completed the infraoesophagus dissection. You can see the left bronchus, the right bronchus, the subcarinal region, the arch of aorta, the aortopulmonary window completely cleared up. You can see both the bronchi are expanding with respiration, and this is the esophagus being lifted up. So you can see this now, the Oesophagus vein is lifted up. This is the right bronchial artery which is preserved, supplying the right bronchus. I always preserve the oesophagus vein which supports the right bronchial artery. Now this is the supraoesophagus dissection in the supraoesophagus compartment right at the apex of the posterior mediastinum. We go posterior, you can see there's a thoracic duct in the posterior aspect of the esophagus, and that's the esophagus which is pulled anteriorly. Then we go in the plane between the esophagus and the trachea, that is the tracheoesophageal groove. The esophagus is lifted up, and now we'll be looking here for the left recurrent laryngeal group of lymph nodes. You can see the harmonic working beautifully here with complete hemostasis. The esophagus lifted up, trachea is retracted, and this is the left recurrent laryngeal nerve, and all these left recurrent laryngeal group of lymph nodes are completely dissected. And the last stage is where we are reaching at the apex of the posterior mediastinum, at the root of the neck, where we are dissecting the right recurrent laryngeal group of lymph nodes. You can see here all these right recurrent laryngeal group of lymph nodes are dissected. This is the esophagus underneath, and very soon you will get to see the right recurrent laryngeal. This is the right recurrent laryngeal nerve. That's the right recurrent laryngeal nerve, which is going around the subclavian artery. This is the right vagus. First branch of the right vagus is the right recurrent nerve, and it loops around the subclavian artery. So that is the complete dissection: arch of aorta, aortopulmonary window, left and right bronchus, the subcarinal group of lymph nodes, and the pericardial group of lymph nodes, inferior pulmonary vein here, and the lower mediastinal dissection, which has already been completed. You can see the inferior pulmonary vein. So this is as radical as you can get with this technique that we have developed in the semi-prone position. We were the first ones to devise this technique in the year 2007. And now this has been accepted as a part of the teaching video library at the SAGES video library. And it has now been published in the South Asian Journal of Cancer as a Pawar technique. Then we do the laparoscopic dissection. You can see the splenic artery, the common hepatic artery, the left gastric artery is divided. That's the pancreas. So celiac lymph node dissection is done. And then next we go to the neck. This is the carotid sheath retracted laterally. The esophagus is divided, and the stomach tube is prepared into, stomach is made into a narrow tube fed through the posterior mediastinum for an end-to-side anastomosis in the neck. So this is a hand-sewn anastomosis we do. This is the specimen with the tumor and all the lymph nodes that have been removed. And you can see these are the 3 ports: the scar number 1, scar number 2, and scar number 3. So that's the end of the procedure, that the technique that we have developed. It has been presented in the World Congress and also presented in the Memorial Sloan Kettering Cancer Center as an invited video. And we have this our own publication of 224 patients recently in the South Asian Journal of Cancer in April 2021, where we have found that the median blood loss thoracic is just 100 ml. Operative time thoracoscopic is just 67 minutes. Median lymph node dissected as 16. And disease-free survival is 18 months. Overall survival is 22 months. And the most recent addition now is the robotic, over and above thoracoscopic, is the robotic surgery. These are the various advantages of the robotic surgery: the 3D picture, the wristed instruments, and the faster overall recovery, less pain, minimal blood loss. All these advantages of the robotic surgery. I don't have to go into the details. This is a study comparing robotic versus open surgery. The robot trial, 54 versus 55 patients, and they have shown that the lower percentage of overall surgery-related cardiopulmonary complications in the robotic group, and better short-term quality of life, better short-term post-operative functional recovery as compared to the open thoracoscopic esophagectomy. There's another paper addressing the RAMI, that is robotic-assisted minimally invasive esophagectomy. Again, advantages in terms of post-operative complication, length of hospital stay, and quality of life. And the biggest advantage is the meticulous dissection along the recurrent nerves in the upper thoracic inlet is a big advantage with the robotic surgery. So I'll skip some of these theoretical studies. Now, this is the only study that is comparing robotic surgery vis-a-vis video-assisted minimally invasive thoracoscopic versus open esophagectomy. And they have shown that minimally invasive surgery could guarantee quality of bilateral recurrent nerve lymphadenectomy with increasing post-operative, without increasing post-operative complications. So these are the advantages of minimally invasive surgery: reduced blood loss, reduced pulmonary morbidity, shorter length of stay, and faster recovery. So this is a robotic surgery that we have regularly doing at our center, robotic center at Palapur Cancer Center. And these are the port placements which I mentioned here: posterior axillary line operative ports, and the camera in the anterior axillary line in the fifth intercostal space. And I'll skip the video. I'll fast forward it. We are in the same process being repeated through the robo. The advantage being the big advantage, the flexible tips that can rotate in 720 degrees in 7 different axes, and the control is better. The camera control, the 3D vision, and let me go fast forward and just show you the important steps and the advantages, how the tip can move in all directions. Now we are dissected the subcarinal group of lymph nodes. This is the left bronchus, that's the right bronchus, and you can see how the tip is flexible, and you can go and reach the very difficult planes sometimes, which are difficult with thoracoscopic surgery. And the Maryland bipolar is in my right hand, the monopolar scissors is in my right hand, and here you can see the entire esophagus is being dissected. That's the arch of aorta. And let me fast forward and show you how the recurrent laryngeal dissection is better. These are the aortopulmonary window, the left bronchus, the right bronchus, the Oesophagus vein again preserved. This is the right bronchial artery supplying the right bronchus. Let me fast forward it. This is a retroesophagus dissection in process because of the flexitip instruments. This is a big advantage. And now we are in the supraesophagus compartment, dissecting between the esophagus and the trachea to look for the left recurrent laryngeal dissection. Here you can see the trachea is here anteriorly. The esophagus is lifted up, and we are dissecting in the superior mediastinum. And here you can see this instrument has completely pulled the trachea anteriorly, which is difficult with thoracoscopy. Esophagus is lifted up, and this is a left recurrent laryngeal nerve, and the entire dissection. More important, the dissection between the left recurrent nerve and the trachea. Here, because of the flexible instruments, I can pull the trachea the way I want, and I can still dissect into this area, which is a big advantage. You can see the entire left recurrent laryngeal nerve dissected, and esophagus lifted up, the trachea pulled here, and we're getting a perfect view of the entire situation. So the left recurrent dissection. Then we go still higher up for the right recurrent laryngeal nerve. Here you can see the right vagus. This is the subclavian artery, and this is the right recurrent laryngeal group of lymph nodes that are being dissected. I will fast forward. So this is, you can see the right recurrent nerve, which is looping underneath the right subclavian artery. And these are the final stages of the lymph node dissection of the right recurrent area. So that's like completing the whole procedure. And you can see the right recurrent nerve, and the advantage is because you can do the fine dissection with these kind of flexible instruments. We don't need a harmonic scalpel, just the cautery, the bipolar cautery in my left, monopolar scissors in my right, and you can still do an equally good dissection, which is a bloodless kind of a dissection. You can see the subclavian artery and the right recurrent laryngeal nerve, and that's the complete dissection, and the mediastinal dissection is completed. You can see the Oesophagus vein preserved, and the entire dissection is completed. You can see the specimen that is removed, and similar procedure as compared. Then we do the stomach tube and the anastomosis in the neck. So this is our robotics department we have at Kolhapur Cancer Center. So minimal invasive surgery is highly skillful art, not for the uninitiated. It is feasible, safe, no oncologic compromise, less morbidity, less length of stay in the hospital, less pain, less blood loss. So the take-home message as far as esophageal cancer management is concerned: cancer esophagus, a debilitating disease. Dysphagia should sound an alarming bell. Multidisciplinary management is important. Chemotherapy, radiation therapy, followed by surgery. Advances in radiation technique with high precision, accurate planning, newer chemotherapy molecules. The surgical technical advancement with the robotic surgery being the latest in the surgical armamentarium. And all these are eventually leading to a better quality of life for the patients with cancer of the esophagus. Thank you very much.
Excellent presentation, Dr. Suraj. Yeah, beautifully done surgeries, and the three
I hope
stages.
I have kept to my time.
Yeah, you have kept to your time.
Thank you, sir.
Suraj, it was a very excellent, a very nice presentation.
Thank you, sir.
So everything can be achieved. The center doesn't matter whether you are in a metro city or whether you are in a third tier city. Yeah, dedication is required, and dedication has paid you very well.
So
nice.
In fact, I would say that the tier 2 and 3 cities are doing more advanced work nowadays than the metro cities.
And Niranjan, you are telling the truth.
Yeah, because one thing what I have realized is that the volume of work which comes to tier 2 and 3 specialized centers is much heavier than what we get in the metro cities also, you know.
Absolutely.
Because here the number of hospitals and the tertiary care are so many that the work actually get divided, and there are so many specialists and super specialists and super specialists that even a colorectal surgeon in the city of Mumbai would get starved to do a cancer work. It will go to a surgical oncologist, you know. So yes, it is, and I'm always proud of Suraj. Is
Thanks,
my
Niranjan.
batchmate, as he has already said, and a seasoned speaker, a very nice presentation. It's
you.
been a good talk all throughout. Any questions, sir?
There's no one is asking any question. In chat box, nothing is there.
Fine. So then it's time to wind up.
Wind up.
Thank you, Suraj. Thank you, Dr. Sonath, Dr. Kamlesh, Dr. Gvalani, and Dr. Meghraj Ingle. Thank you for obliging us at short notice and doing the deliberations today for the benefit of our delegates. Rajesh, are you around? I don't see you.
Yeah, he's there.
Yeah, he's there.
Very
Okay.
much.
It is your prerogative. Please go ahead and
carry on,
initiate.
Niranjan, no problem.
No, I didn't see you. That's why I was thanking them. Please do it. Please do it. Please.
Thank you all the speakers and our chairpersons. Thank you, Dr. Abhay Dalvi, sir.
Hey, sir, let sir talk. Dr. Abhay Dalvi is there if he has to comment something. Dr. Dalvi, sir? Yes, sir.
I will ask
Yes.
Suraj my personal questions later.
So it's a Friday evening and Niranjan already warned me.
There was a condition before I allotted him this.
Suraj was my student and has done an excellent job in Kolhapur.
Yes,
we have
sir.
enjoyed multiple evenings together. And let me tell you, this person has risen from scratch. Okay. So if he is going to go on going after advancement in surgery, my blessings to him as a senior person, surely enough. Okay, I joined this entire thing because of Dr. Gvalani, as I said earlier, and then I found Suraj Pawar. So one is my senior, one is my junior, and it was an excellent presentation from both, including the Dr. Ingle, who is a gastroenterologist. Excellent presentations, and I think I have to congratulate Niranjan, Rajesh, and the chairpersons. Kamlesh, कभी भी तो आने दो अंदर. Anyway, so excellent. I'm donning the mantle of ASI president here, and wonderful exposition of what you can do. I have my reservations. I will come back to the people personally. Thank you so much.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you for
Thank you,
being
all of
around
you.
always and
We had a
blessing us.
very-
17th, where Chetan is coming in, Sharvari is coming in, and next week.
Yes, sir.
They're on the roll. So I'm there with you.
Yeah,
Whenever
thank
I'm
you, sir.
free.
So I know, sir. You are always there, and that is what is our biggest encouragement.
The problem is useless commitments. Anyway, let's face it.
What is useless?
Kamlesh? Kamlesh?
Yeah. I'm
Yeah,
there.
you were a treasurer, and I protected you someday.
Yeah.
So you realize what is useless commitment.
No, what you No, nothing is useless. I think your contribution to the surgery
Not like that.
is
When you take
phenomenal.
Listen,
And you are
when you
dedicated.
take some position, you have to be absolutely non-committal, and you are sitting in a chair. And then when you get an opportunity to accolade people who have taught you or who have learned from you, who are doing excellent job, we have to be there. That's why I joined this. Last week I did not join, but Dr. Gvalani as well as Suraj have done so much for society through this corrosive poisoning or thoracoscopic esophagectomy is humane. It is not easy. Can we think of raising something in Mumbai like Suraj has done and advanced, or Dr. Gvalani, who has gone ahead with his commitment to corrosive esophageal strictures, is humane. Can I do it today? Can we do it today? It's impossible. It's impossible. At a given point of time, hands start shaking. All of us realize that. So just to tell you, wonderful session, Niranjan,
Thank you,
Rajesh,
sir.
Thank you, sir.
Kumar, so
Thank you
much.
so much.
Loved it. Thank you.
Thank you,
Thank
sir.
Thank you,
Thank you,
sir.
everyone.
Thank you so
Thank
much.
you, sir.
Thank you, Juventus, and thank you all the panelists as well as the chairperson. So we'll wind up this session. Thank you all. See you on next Friday.
So much. Thank you.
Okay.
Done.
Thank you.
Thanks, Niranjan. Thank you very
Thank you
much.
so much.
Bye.
Thank you,
Thank
Niranjan,
you,
sir.
Okay,
Suraj.
Suraj. So
Bye.
nice.
Nice seeing you.
Gvalani.
Good night. Good night.
Bye.
Good night.